Good afternoon, everybody. My name is Ole Keen, and it's my great pleasure as President of the Federation of European Neuroscience Societies, FENS, to welcome you all to this joint webinar hosted by FENS and the European Stroke Organisation ESO on the topic Stroke and Dementia from the clinical question to neuroscientific background. This webinar really marks the first activity under a new ESO-FENS Strategic Alliance, a collaboration which is launched today. And the alliance aims to bridge the gap between basic neuroscience and clinical stroke research, and also fostering impactful neuroscience and translational science. And under this agreement of ESO and FENS, we have decided to co-develop at least one joint event annually, share communication platforms, and promote each other's educational initiatives. And today's webinar is an ideal example of this joint vision in action. By uniting clinical and basic science perspective, we hope to advance research and attract new scientists into both of our communities. And with this, I would like to bring a special thanks to the organizers and to this webinar's two moderators, Professor Karen Doyle and Professor Peter Kelly, the recent past presidents of ESO, and to our two outstanding speakers, Professor Anna Velho and Professor Rai Kalaria, whose contribution to the field of cerebrovascular diseases are actually extraordinary. And with this, I would like to hand over or wish you all a productive and stimulation session and hand over the word to Karen Doyle.
Thank you, Ole.
Peter, actually.
So nice to be here with you all, and I wish you a very warm welcome to this joint FENS and ESO webinar. I think we have a great topic to discuss. We've got great speakers and very strong interest in the webinar, with many hundreds of people registered and online with us at the moment. So excited now to introduce our first speaker. Our first speaker is Professor Anna Verdelho from Lisbon. Anna is a neurologist in the Department of Neurosciences at Santa Maria Hospital in Lisbon, and also a professor in the medical school at the University of Lisbon. And Anna has a very strong clinical and translational interest in cognitive decline and dementia in cerebrovascular disease. And the title of her presentation is very simply Dementia and Cognitive Decline After Stroke. So Anna, you're very welcome, and the floor is yours.
Thank you. Thank you for your kind words. It is my pleasure to be in this first joint initiative. I will try to give you an overview on the topic of post-stroke dementia, or I should say on post-stroke cognitive impairment. Dementia is only the most severe stage of post-stroke cognitive impairment. So this is what I will try to give, and I will approach very briefly some possible mechanisms. I will go into the cognitive characteristics and how to approach those patients, and finally some treatment considerations. I will start to present you the clinical picture of my patient Maria, with 80 years old. After her first right hemispheric stroke, she improved quite well. She had months of stabilization, and then something happened. It was not clear. She went to the emergency room, and imaging did not show any stroke, but she had a pneumonia at that time, and since then she started declining. And in fact, the prevalence of post-stroke dementia is quite variable, between 7% in population studies until more than half of stroke survivors in hospital cohorts in recurrent stroke, and it's higher in patients with previous decline. In general, we can say that a third of stroke survivors will have post-stroke cognitive decline or dementia at any moment after stroke. Considering cognitive decline without criteria for dementia, and these include focal deficits, that are the result of stroke, like aphasia or neglect or some attentional deficits, when they are just isolated, one single cognitive domain, it can reach as high as 80% of stroke survivors. And is even high among those who have no physical disability, who are considered with a very good physical recovery. The recognition of cognitive impairment after an acute vascular lesion has been complemented in recent years by the knowledge that cognitive impairment can appear even after transient lesions, even after a TIA, and underlining the role of vascular disease as a phenomenon that goes beyond the scope of the lesion itself. Sarah Pendlebury and the group of Oxford shown very nicely how a major stroke anticipated around 25 years the diagnosis of dementia, a minor stroke with very less small sequela around 40 years, and a TIA can anticipate for 3 years, so making clearly stroke a risk factor for dementia. Among stroke survivors, who is in higher risk to have post-stroke cognitive decline or dementia? There are factors associated with the person itself, with conditions of previous to stroke, and with the stroke itself. So consider the factors associated with the person itself, age, female sex, and previous level of education, this as a protective factor, are very much associated with a higher risk of cognitive decline. There are factors like previous conditions, high diabetes, hypertension, smoking, previous temporal lobe atrophy, previous white matter changes, or previous cognitive decline that are associated with higher risk as well. And finally, conditions associated with stroke, like the severity of stroke, the sequela of stroke, and the complications of the acute stroke event. And this was recently confirmed in this systematic review with meta-analysis. Post-stroke vascular cognitive impairment is highly heterogeneous, as it includes any cognitive deficit after the stroke, irrespectively of the presumed etiology, irrespectively of the severity, of the concomitant or not behavioral symptoms, of the concomitant or not functional impairment due to physical symptoms, and irrespective of the time elapsed since stroke. And it's easy to understand that Maria, my patient, had that kind of evolution over time, but different time of trajectories can be found in stroke patients. And this makes the issue even more complex and difficult to identify. Partially, this evolution is associated to the different mechanisms associated with post-stroke cognitive decline. Aside from the damage associated with the lesion, with the focal signs and the symptoms of the hyperacute stage, we have what is called by some authors the transient cognitive impairment, something that is not very well understood. It's an acute change of the first few hours after the event, eventually caused by the inflammatory process or a cholinergic deficit. And it's different from the concept of delirium in the context of an acute disease. And we still do not know many things about this entity. Then we have two different possible ways to go after stroke. We have those patients who have a progressive deterioration soon after the stroke event, like it was an anticipation of a latent Alzheimer's disease or a previous neurodegenerative disease that was just waiting for the acute lesion to become more express. And then we have, and this is sustained by the characteristics of this type of patients. They have more frequently a higher frequency of hippocampal atrophy. They have more frequently the epsilon E44. They have more frequently previous cognitive decline, and they start to decline very soon after stroke. And this type of patients receive more frequently a diagnosis of Alzheimer's disease, even though they had a stroke, than a vascular dementia. And then we have another type of patients that can have some stabilization over months, and then they start to decline slowly. And these patients are more frequently those who have more white matter changes and more subcortical lesions. And this has been postulated as a vascular disconnectivity syndrome, same thing at distance. And these patients can be diagnosed as having a depression, although they are not sad. And they might be suspicious of having depressive symptoms that are already the first manifestation of the more type of vascular cognitive impairment that is progressing. This was described in different studies. Levine and colleagues found that in more than 20,000 of participants, that more than 500 had were survivors of a stroke, that after a moment of recovery or stabilization, they start to decline in global measures or in executive functions. And this was clearly different for the patients from the community that did never suffer the stroke. And Jessica Lowe showed the same. They showed that in 1,500 stroke survivors that had in the first year some recovery and then started to progress. And using MRI, it is possible to document, I just show you here an example, how a subcortical lesion can make this disconnection to the cortical and is associated with cortical thinning and with subcortical changes associated with a subcortical lesion, not related with that cortical distant evolution over time. This was try to be understood in the laboratory, in the experimental animal. In fact, what it was done, it was that it was clamped, an artery not supplying any memory areas, and the animal was tested before in this Morris water tank. He learned how to reach the safe surface, and after being clamped to that artery that was not responsible for a memory area in the brain, the animal forgot how to reach that hidden platform that was safe. And this was sustained in several research. And after the animal was dead, they found that was gliosis and atrophy in the remote areas responsible for memory that were not involved in the stroke itself, so sustaining the same type of mechanism that I mentioned before. Nowadays, we know that is frequent, mainly in the aging brain, to have several neurodegenerative diseases together in the same brain. And due to this, some studies approach the reason why these patients decline so long after stroke. And I show you here some examples of studies using PET amyloid tracers in stroke survivors. And they did this in stroke survivors many years after the stroke, and they was declining, and they found that most of those patients were amyloid negative. So sustaining this vascular effect in stroke patients. Of course, we cannot say with the amyloid tracer that we are not with the TDP or with the tau pathology, but at least we can show that it's not due to amyloid disease. The cognitive profile of stroke, of post-stroke, can be as well heterogeneous due to all the reasons I mentioned before. But there are some cognitive domains that are usually more damaged after stroke beyond the typical deficits due to stroke itself, like aphasia and neglect. And those are attentional abilities, executive functions, processing speed, and working memory. And executive functions means that ability to initiate, planning, organizing, and completing actions that are so needed for daily tasks. This said, global measures of cognition might fail to diagnose this type of deficits. I'll show you here the most frequent tools used in my country, Portugal, but you can have others. The only thing is that even if you use more adapted tools for executive functions like the MOCA or the Edinburgh, be aware that although they are more specific for executive functions, they are highly influenced by educational and cultural level. So you must be cautious when interpreting the results of those tests. If possible, patients suspected from post-stroke cognitive impairment should undergo formal neuropsychological assessment whenever it is accessible and feasible. The neuropsychological assessment must include an evaluation of the cognitive domains most affected, and not to forget previous cognitive status evaluation and the neuropsychiatric symptoms that are very frequent in stroke patients. If you do not have neuropsychological assessment available, nevertheless, use the screening tests and be suspicious, because any point lost, mainly in younger stroke survivors, are meaningful points. There are already some screening tests created specifically for stroke patients. I show you this example, the CASP scale. They are more adapted for neurological sequela as neglect, and they avoid verbal measures. They introduce the memory tests using visual cues, and then can be very useful if you have it translated in your country. And I show you here also an example how the very popular memory test that is available on net, and general people use it to test and to train memory, how it was used to try to screen type of post-stroke impairment. Of course, it's too much dependent memory. It depends on visual images, but nevertheless, you can have several ways to approach cognitive evaluation in stroke patients. Brain imaging is essential to prove the relation between the lesion and cognitive impairment, and MRI is the more sensitive and specific tool. But you need to remember that you need to use the specific sequences as diffusion for acute lesions and small lesions, and susceptibility weighted imagings or gradient echo for hemorrhagic lesions, aside from the T1 and the T2 usual used. There are other sequences like a diffusion tensor that can be used in research purposes, but for the clinical use, they are really not needed. Again, if you do not have access to MRI, CT is a useful tool. It will identify very easily hemorrhagic lesions, and even most of the stroke acute lesions can be seen very easily with a CT. Just a few words on treatment. If we ask the ChatGPT what's a good outcome after stroke, you will be surprised because despite everything I said, ChatGPT does not consider cognitive status a clear good outcome after stroke. And this is highlighted more than almost 10 years ago that a functional and physical recovery is not enough to consider a good outcome, but still ChatGPT did not learn that. And in fact, there is a lack of studies, of very good studies on this topic. And no surprisingly, we have no pharmacological treatment approved for vascular cognitive impairment after stroke, either mild or severe as dementia. But of course, that no evidence that the symptomatic treatment for Alzheimer's disease is effective in pure post-stroke dementia, but if we admit a mixed etiology, we can use it, and the vascular side should not be considered a barrier to anticholinesterase nor to memantine. But they are not a recommendation per se that the vascular disease should be treated with this type of drugs. Differently from stroke prevention, studies with drugs that can prevent stroke found no evidence that those same drugs might prevent cognitive deterioration after stroke. And so we have a limitation on that behalf on the recommendations, like it is expressed in the joint guidelines produced by the EAN and the ESO. A recent open study using silostazole gave us promising results, and we will now probably need a randomized and blind trial to confirm these results. For now, treatment largely involves general health promotion measures, optimizing the correction of vascular risk factors and stroke prevention using recommended secondary prevention measures. And we have reasons to be optimistic because we know that the reduction of incidence of dementia in several countries is clearly reducing, and this is mainly due to the reduction of burden of vascular neuropathological disease. So we have reasons to be optimistic. We ourselves tried to do an after on that behalf. We did a randomized trial using physical activity, and we use a digital tool using a functional training that allowed the patient to train executive functions, the initiating, planning, organizing things, to go to supermarkets and buy the food needed for a recipe or for doing a meal. And we are trying to explore this type of interventions. So to conclude, while the degenerative phenomenon in many stroke survivors remain to be fully understood, we know as well that there is a partial reversibility over time that we can take as a good news, and we make an effort to prevent further strokes, to prevent cognitive functions, and we need to have further studies on the topic to progress. So this is the reason why I think this type of webinar is really a good idea. Thank you for your attention.
Thank you very much, Anna, for that amazing talk. That was really, really, really interesting. I'm sure that many of the audience will have lots of questions for you. Can I just ask that the members of the audience, please, if you could pass your questions through the Q&A button that's on the Zoom. And we will pass your questions on to Anna. But first, we're going to move on with Raj's talk. So it's my pleasure to introduce Professor Raj Kalaria, who's head of the neurovascular research area in the Translational and Clinical Research Institute at Newcastle University in England. He's a professor of neuropathology with a focus on cerebrovascular diseases, and he's also a neuroepidemiologist. Raj's interests include the interface between Alzheimer's disease and vascular dementia, post-stroke dementia, and small vessel diseases of the brain. And today, Raj is going to talk to us about life after stroke, light from the COG-FAST study. Thank you, Raj.
Thank you very much, Karen. Ladies and gentlemen, I'm also very grateful that FENS and ESO have invited me to talk to you and share some thoughts and some information and research that we have gathered from the COG-FAST study, which stands for Cognitive Function After Stroke. And this was a Medical Research Council study funded for the last 20-some years. And as you may also know, Newcastle is an important center for dementia studies going back to about 50 years. And so particularly for dementia Lewy bodies, although I am I think the sole person at the moment flying the vascular flag, if you like. So just to change, doesn't seem to want to go to the, okay. So this is just summary of my presentation, and I really want to focus on the questions that are in bold, the types of dementia that develop after stroke, and very much in line with what Anna has already shared with you, some information on the neuropathology of PSD or post-stroke dementia. And I want to talk about the white matter in particular, and of course, some of the risk factors too. Now, may I share just a couple of points about historical aspects. And I think looking at this scheme, the pendulum has swung from, I think, all things vascular to the hype of Alzheimer's disease. And then, of course, we've now come back, I think, to vascular things, which is really for my liking. And VCI, vascular cognitive impairment, VCD, vascular cognitive disorders, and the VIX consortium that has defined, which I'll come back to. But I think you should note that in Newcastle in the mid-60s and late 60s, there were two seminal, I would say, discoveries, or perhaps rediscoveries, if you like. One was that the burden of neuritic plaques at post-mortem was related to cognitive dysfunction ante-mortem. This was a very important seminal point or information that was published. And then the other point, I think, which relates more to my talk, is that the loss of tissue, 50 mils to 100 mils after a stroke, was also related to cognitive dysfunction. So this is, I think, the contribution that Newcastle made very, 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 very appropriately. And then, of course, things have come that way. Now, looking at ischemic stroke, if you like, the stroke today, I think Anna has already emphasized some of these points, but the risk, the number one risk factor is hypertension. I'll come back to that. And then, of course, multiple lesions are order of the day, as this 3,000 scan study, MRI Gini study, which really brings that whole picture of ischemic stroke, particularly to light in Western Europe and probably North America. And then I mentioned VCI. So the VIX consortium some years ago in 2018, the last paper that was published, this is a consortium involving about 50 or 60, about nearly 60 investigators. And VCI as a concept was difficult in the sense of managing and, of course, diagnosis and so on. So then we thought, how do we clinically manage this? So we have to then divide VCI into sort of mild form and measure. So measure really equates to vascular dementia, if you like, and mild where they may have deficits in one or two cognitive domains. But major VCI was then as a clinically significant deficits of sufficient severity, at least in one cognitive domain, and that could be in, for example, executive dysfunction. So this was an important, I think, milestone. And then, of course, under VCD, you can have post-stroke dementia and other types of vascular dementia or subcortical dementias that are of vascular origin, which may or may not have some sort of neurodegenerative pathology. Now, all of these conditions, as the slide comes up, are related to VCI. One can have mild, one can have very severe, progressive severe, and VCD, as you know. And I think the one scheme that I want to point out is really the small vessel disease. These are the individuals who are going to live long with small lesions, and really there are consequences down the road. So the idea then is, do they improve? Do they remain stable? Or do they decline? And if they decline, what type of problems, in particular dementia, do they develop? That's the question. And so some years ago, we kind of considered this very carefully. We really wanted to study the effect of hypertension on dementia, but this is very difficult because of comorbidities in old age, as you know. So we then looked at stroke in terms of the first stroke established by a CT record, and then follow them subsequently as long as we could. And so that was the idea. So at baseline, 3 months after the stroke, after all the delirium and the confusion sort of subsides and dies down, we can now, at baseline, they have a cognitive score or MMSE score that's nearly 29 to 30, so they're almost cognitively intact. And then we can really look at the impact of that first stroke down the road, as it were. And so this is the plan of our COGFAST study, basically the design where we had enrolled individuals, elderly over the age of 70, first stroke, and then they screened annually over time with also taking bloods, and of course they also some of them also were imaged at baseline, but also some more at subsequently. And then we had other groups as well, control groups, and for example, individuals who were already diagnosed at baseline with Alzheimer's disease, vascular dementia, and mixed. So that's the idea. And then Newcastle has a unique program, a longitudinal program, as is mine in vascular, but also in DLB, where we follow the patient from the clinic to postmortem. And I think this is an important clinical pathological way to really see what is in the clinic, and then what we can look at the brain at the end of the day, as it were. And I think this is very, very informative. So what are our overall findings? I think on the right, the glass is sort of, if you like, half full. They lived long, some improved, and there was a better chance of them surviving even another 5 years if their risk factors were controlled. But the glass is half empty if they they had more than 2 or 3 vascular risk factors. Those we're talking about hypertension, diabetes, and sort of changed lipids, etc. And if we didn't control them, then that was bad news, either to death or to progress to dementia, as the survival curves show. And so what are some of the factors that are contributing to this? White matter lesions, particularly the burden of them, and medial temporal atrophy, which I think Anna has already mentioned. And then, of course, changes in blood flow, particularly the variability in blood flow. And I'm not going to show you all of these, but some individuals were also succumb to depression. But at the first sort of data at 8 years, we found about 25% developed what we call post-stroke dementia, PSD, with an average follow-up of about 4 years. Neuropsychological features were executive dysfunction. There were some memory deficits. And then medial temporal atrophy, as I mentioned. Now, when we looked at the brains, the first 50 brains that came to postmortem or autopsy, they had very little, or as it were, just a little bit of a normal aging amount of amyloid or neurofibrillary tangle burden. So these individuals were largely free of any amyloid or tau, if you like. And so it's kind of a perfect experiment where half we found developed dementia and half didn't. And then, so what are the other factors that really, if you like, drive them or get them over the threshold to dementia? Looking at longitudinal data, many remained relatively stable over many years. But the implication is very clear that before they developed dementia as such, the pattern really showed that 3 years before in particular, there was a stepwise decline, and the message to the clinicians is really supporting strict control of vascular risk factors in these stroke survivors. These are individuals with small lesions. And here's a one case, for example, of a 99-year-old Caucasian right-handed man who was stable, as you see in the CAMCOG scores there, or in the red, and then below the MMSE scores, quite stable for a number of years. And this individual had quite a few small lesions, and he also, for example, he went on all sorts of adventures, including a safari in Botswana, etc. And of course, his vascular risk factors were controlled, but then eventually he succumbed to a medium-sized infarct in the cortex, then and died thereafter. And came to postmortem, of course, and we could look at his brain. Anna has already mentioned this, and I just want to say that, yes, it's quite variable, about 10% that Sarah Pendlebury and Peter Rothwell have shown that developed new dementia soon after the first stroke. And I think also they mentioned that we didn't know about medial temporal lobe atrophy was a substrate, but we can now confirm that that is a substrate for without amyloid and without tau. Looking at the global data, we are finding what is really in the range as shown here in this slide with post-stroke cognitive impairment, PSCI, about 30 to 40%, 3 months after the stroke. So if our data fit very well with what's been shown. And then, of course, the Meta-VCI consortium has now pooled data from a large number of studies and suggested that the left frontal lobe is the main strategic infarct location predictive of PSCI, or post-stroke cognitive impairment. And this is a very important, I think, consortium result that was published a few years ago. And also, I think I want to make the point that white matter was an important substrate. So here we have, I just want to share with you some data on the white matter pathology. So as I said, in life, we followed them and we looked at white matter hyperintensity volumes, as you see in the images here. those who remained stable had a little bit of decline, and then you have the others who are really the decliners who went on to develop dementia. And so white matter hyperintensity volume was an independent predictor of survival to dementia. And these individuals came to postmortem, so we looked at the brains. And to cut a long story short, what we found was that the gliosis, particularly astrogliosis, was one of the predictors in terms of driving the process to dementia development. And so these are astrocytes that become hypertrophic. They absorb plasma proteins and then they retract the processes and become what we call plasmatodendrocytes. And these were all in the white matter, and very, very, very clear effect on the frontal white matter of those individuals whom we had followed in life as well. And just to then share that, I'm sorry for this, a little bit of pathology here, but basically what you see in panel D at the bottom in the middle is an astrocyte that's become hypertrophic, and then it retracts the processes. And so what it does is basically the end feet are removing the water channel molecule aquaporin and now disconnecting with the capillary wall. So it's something that's quite an important phenomenon, and this occurs. And then the astrocytes basically die of the process of autophagy. And that's really what this paper that we published some years ago showed. So aberrant co-localization of aquaporin in retracted GFAP plus astrocytes. And then this is all related to the blood-brain barrier damage linked to the deep white matter in frontotemporal brain. Now, so that's basically the pathology, if you like, in the white matter, sort of disconnection, as I think Anna also emphasized. Most of our postmortems that have now, we've collected about nearly 100 brains out of this study, starting out from about 700 individuals in life and then whittled down to 500, but 100 autopsies or postmortems is very good. And half of them had dementia before they died and half didn't. So perfect experiment in the sense to compare. And most of these had small lesions, small lacunes, small infarcts, small vessel disease type of changes, and white matter damage as well, as I mentioned. And looking at some of that data, again, what separated the individuals who didn't develop dementia after stroke against those who did develop dementia was the white matter location of white matter infarcts. Now, taking this further into sort of translation, if you like, is we looked at some animal models, and here particularly I want to bring up a model of what we call the lateral carotid artery stenosis model, where we put a kind of basically a small coil, which is like basically a piano wire wrapped around the carotid arteries. And this is quite an established model. But here's the result I want to show you. So over time, these mice, they acquire small lesions, particularly small microinfarcts and infarcts, cortical and subcortical. And when we put the mice in an enriched environment, either for 3 hours or full time, by enriched environment, I mean that they have got all these toys in the cages, and they've got these tunnels and all kinds of attractive things and spinning wheels and so on. They keep spinning, etc. We found that those that were put in environment enriched cages reduced their subsequent strokes, many strokes, by 50 to 60%. This is a remarkable result. Now, we can't get stroke patients, of course, to do all the physical activity, if you like, or at least environment enrichment type of scenario because very apathy sets in. But this is a good point to remember and learn. Now, and I think this is just to summarize that you're really getting a structural disconnections, cortical, subcortical disconnection that I think then is contributing very importantly to cognitive impairment. And just lastly, I want to just turn to our data in Africa. Now, we, as in Newcastle, we had the COGFAST study. Some years later, we started a COGFAST study in Nigeria, in Ibadan, because we have good collaborations with them, and also different environments, different lifestyle, different diet, etc. We thought, so why not look at stroke survivors in Nigeria? And that's what that happened. And so I just want to show you the Nigerian data, although we have Tanzanian data and Kenyan data. So very similar to what we found in Newcastle. These are 10 years younger individuals, and the burden of post-stroke cognitive impairment, as well as medial temporal atrophy, was just about the same, even with different diets and so on. Now, you might wonder, how do we do neuropsychological tests when individuals might have never put pen to paper? And this is just one example here showing you that we asked them to basically repeat or see that fork that you see in the middle of the screen with matchsticks to reproduce that, and then that can be scored. And you can see the examples that come up with those individuals who had impairment. And in terms of the predictors of post-stroke VCI in the Nigerian, age, of course, and education, but eating daily fish pre-stroke was absolutely protective. So here's the message. Daily fish intake is a good thing. And longitudinal data, trajectories for the new Nigerian study, again, education came up as an important substrate, particularly protective. You had higher education, and then, of course, increased functional dependency over time, and that was more or less predicted in our Newcastle study. Eating leafy vegetables was also protective, and also inversely associated with hypertension and incident stroke. So fish and leafy vegetables, a good message. Now, I don't want you to, if you are in a big room, don't raise your hands. If I'm going to ask you a rhetorical question, how many of you know your blood pressure? And perhaps you might just, if you're in a big room, you might embarrass yourselves. But so don't raise your hands, but do you know your blood pressure? And there are individuals like this in Africa, in one of our participants in Africa, with that figure. Now, they're walking, talking, and it's really basically a time bomb, isn't it, so to speak, quote unquote. And so if we do at least just go with one of those risk factors, there are many, as I said, vascular factor. If we just control one personally, perhaps, at a personal level or a community level, we can, or even at a country level, we might be able to then impact on the burden of dementia, as suggested by the CFAS study some years ago, although they didn't look at vascular factors in particular. And I think we can also then say that really vascular disease probably precedes all of this other stuff that is associated. Sorry for being tongue-in-cheek here, but that's I think the scenario we're getting and what we look from our studies. And I just want to say that in a scheme of things, this is kind of a working hypothesis where you have a vascular perhaps insult or a vascular event, initially hypertension as being one of them, that maybe changes the vessel wall and creates what we call a hyperperfusive state, an oligemia, a word that's not been used very well, very often now, but it's a wonderful word, and it's just absolutely describes what it means. So this hyperperfusion then perhaps causes the white matter damage and perhaps drives this whole pathway to one way or another, depending on some of the other factors that are there, including air pollution. I didn't mention, but that's there. So here's the final message. Yeah, and we're not advocating you drink, but if you drink, moderately. And of course, stop smoking is a real message, isn't it? So thank you very much for your attention. These are the individuals who help us all through the ages, and very, very grateful to all of them. And I just happen to travel everywhere. Thank you. And our African team as well.
Thank you, Raj. Wow, two fantastic talks there. Absolutely wonderful. So I was focusing so much on Raj's slides and his talk and his message that I haven't even glanced at the Q&A here. So let me have a look and see what we have coming in. We have several questions from the audience. Let's see here. So here's one for Raj. It's from Sophia Mabromati. Great talk. Did you find any differences or similarities regarding the aquaporin 4 GFAP staining patterns when comparing vascular dementia with other forms of dementia?
The answer is no. And in the vascular cases, there was a clear difference. There was a regional difference, particularly frontal lobe and temporal. And so although we haven't published the data, but we did see when you have white matter lesions, for example, in Alzheimer's disease of vascular origin, there's certainly we see the same sort of plasmatodendrocytes or retraction of the astrocytic feet and the change in aquaporin.
Thanks, Raj. Quick one from me, just to follow up on that. Do you have a sense as to what is the immediate trigger for that process on the astrocytes? I mean, maybe you summed it up in your last slide. I mean, maybe there's, maybe you've already addressed that, but what's your sense as to what the most potent driver of that process is?
I really think it's from the circulation. I feel that it is circulation derived, because I haven't shown you the data from the animals, both non-human primates, very similar with the plasmatodendrocyte process and the BB damage, and from the mice. Now this was all non-invasive, so they express the very similar phenotype in terms of the cellular changes in the white matter. So I really feel that something is from systemic circulation.
Yeah, and may I just point out what a powerful design you have there with a very long prospective follow-up neuroepidemiological study combined then with a systematic neuropathological assessment. It's very, very rare. I would almost guess unique to have the two in combination. It reminds me a lot of what C. Miller Fisher used to do for the patients in his practice. He would follow them individually for a long, long time and then do autopsy studies, and we learned a lot from that. But he was doing a series of N of 1 studies, whereas you have a cohort, which I think is very powerful. But over to Karen.
Thank you. I really appreciate that comment, Peter. I think we pride ourselves. I'm so glad that MRC saw some sense, but now MRC has stopped funding us because they want blue sky research. But I think these longitudinal studies have produced so much information,
Right.
and very useful. Yeah.
Yeah.
Thank you. So there are loads of questions in the chat. If we don't actually get to answering your questions or putting them to our speakers, we can try to reply to them offline. There's a question from Sinead in the Q&A, Anna, and she's asking about, do you agree with the differentiation of PSCI no dementia to the way it's currently differentiated, and is querying, basically it doesn't seem to fit that somebody with moderate executive dysfunction impacting function but stable and improving with rehab would be classified the same as somebody with post-stroke progressive dementia. So could you comment on that?
Definitely, yes, yes. There's a distinction, and that's why this very broad topic, post-stroke dementia, is many things together, because it's too much heterogeneous. Because you can have a sequela, simple sequela, executive functions, as you are mentioning, or aphasia that stays relatively stable in one patient, for instance, a young patient that remains stable for decades with that deficit without progression. And then you have other patients that progress, and those are those who have more typically small vessel disease or other markers of vessel deterioration. You have the other group, the group of degenerative disease like amyloid that progressed sooner. They were probably already Alzheimer's disease, not very expressive. And then you have the group of the degenerative vascular disease progressing. But there's a differentiation. I could not say that it's different moments of the spectrum. No, it's probably different diseases. But they are all identified after stroke, probably because the attention was because of stroke. But then we have many different diseases, and they. I think there's someone that asked about the personalization of intervention, and I think this is very important to see what type of patient, as Professor Calaria said, what type of patient you have, what profile, in what. Yeah, it's different. I think it's different.
Yeah. Absolutely agree with that. Thank you.
I'm very conscious of time. We have 2 minutes left. So I'm going to try to ask Anna to squeeze in a very brief answer to a very big question. So Anna, so we have several questions in the chat about various medications, piracetam, citicoline, cerebrolysin, and I think the brief answer is that we don't have high quality randomized trial data showing benefit from those agents. But that leads on to my question, which is how can we generate that RCT data? What do we need to do that we're not currently doing?
I think we would need a very big multi-center study, taking all the people that is devoting to this and trying to collect different simplified information. But we need to try it because the studies did not show a significant clinical effect. So no drug is approved, no drug should be used. But I think we need a larger trial with larger effort, maybe in the setting of ESO and of FNS, to put it en route.
Okay.
Why not?
Thank you, Anna. Okay, quick final comment from Raj, and then we need to close. We'll hand back to Ole, perhaps, to close us.
Thank you. Anna, what do you think about silesosol?
I think it's promising on the setting of lacunar stroke. It's just for small vessel disease. It's not for the larger. I think it's promising. I think we need a close. It was an open trial. That's the problem. We don't have a randomized blind trial, but we need. It's promising, I think, but not yet.
More to do. I think we're on the cusp. It has been a wonderful webinar. Ole, over to you to close us out, please.
Thank you.
Yeah, it's been a wonderful webinar. It's been really interesting to listen to both of these talks and the discussion. Also, the many questions that we have unanswered from the Q&A. I hope that you will have a chance to attend to some of them. It's really wonderful to see all this research that's going on in this particular field, and it's been a wonderful thing for the first webinar that we have between FENS and ESO. And I would also like to thank all the participants that have listened into this. And if you have missed it, or if you can tell your friends that have missed it, it will be recorded so you can see it again and listen to these wise words. So thank you to the panel, and thank you to the moderators and to all the attendees. And with this, we're going to close the session.